Thank you very much. We move on and touch now on a topic that was mentioned briefly earlier this morning, which is mental health, with Professor Maria Melchior. She's from French INSERM, as I'm sure you'll see on the first slide. She got a PhD in social epidemiology at Harvard University, and her research focuses on social inequalities in mental health, with in particular emphasis on development trajectories from childhood to adulthood and the intergenerational transmission of psychiatric disorders. Without further delay, I'll give you the floor, please.
Good morning, and thank you for the introduction and most importantly for inviting me to this meeting. As Pierre mentioned, I'm an epidemiologist at INSERM, the National Institute for Health and Medical Research in France. And for the last 2 years, I also have the privilege of heading the Department of Health in a new institute which was set up in France, the Institut Convergence Migration, which we translate to the French Collaborative Institute on Migration. And I just want to take this opportunity to advertise it a little bit. It's a very interdisciplinary institute which aims to bring together researchers from France, mostly working on different aspects of migrations, including health. And we also aim to link with other organizations internationally. So, anyway, everything is on the website, and I hope there will be opportunities to exchange. What I'm going to talk about is migration and mental health, which is probably an impossible topic or even an absurd topic, and we've heard about this already this morning. Talking about migration in general probably makes no sense at all because there are so many different categories of migrants and so many different types of situations. And what I'm particularly interested in as an epidemiologist is the population health aspects of this question. So just as way of introduction, this was already brought up this morning, but of course in the global world, migration has become even more normal in a way than in previous decades. It is estimated that there are over 250 million international migrants worldwide. We think a lot of Europe, but actually most migrants are in southern countries, in Asia in particular. This is something we probably don't know enough about in Europe. And the persons that we tend to focus most on and who've received most media and probably institutional attention in recent years are refugees and asylum seekers, who are actually only a fraction of migrants in the world. Of course, they have particular situations and great health needs, so I'm not saying it's not important to focus on refugees and migrants' health, but I also think that this topic of migration and health should be put in a broader perspective, because sometimes, and actually as you will see in my slides, I talk about migrants, immigrants other times. I mean, I think there's also a lot of confusion about the terms we use, what we think, what we have in mind, and what decision makers, but also did the general public have in mind when we talk about migrants. In France, this is very obvious. Anyway, I think this needs a little bit more of a broader perspective. Just focusing on the European Union, you probably know this already, but I just thought it was important to remind us of it. There are approximately 4 million new immigrants in Europe every year. Approximately half of them come from other European countries, so of course, this is what the European Union is meant to implement, actually. In terms of absolute numbers, in 2017, these are the most recent figures I was able to find. Countries with the highest numbers of international migrants in Europe were Germany, the UK, France, Italy, and Spain. But in terms of relative numbers, this is something that was also brought up this morning, relative to the population size, the countries that actually host most migrants are Malta, Luxembourg, Cyprus, Ireland, and Sweden. And of course, probably the context in which people live, this is why I'm bringing this up, the context in which migrants live, as well as the general public's opinion regarding migrants may vary with those absolute as well as those relative numbers. But of course, migration in Europe is not a recent phenomenon, and actually you may know this already, but approximately 20% of households in the European Union include a first or second generation migrant. This is overall approximately 55 million people across the European Union. And again, most of them come from another European country, but there is a fair share of people living in Europe for a long time or already for a couple of generations who are from elsewhere. Actually, the majority of immigrants in Europe are long-term settled. That is, they live in Europe for more than 10 years. And I'm sorry, this is not very easy to see, but those certain countries have a longer tradition of immigration. The United Kingdom, for instance, which we mentioned, but also France. And I'm going to show you some data from France, so I think this is just important as a way of introduction. Especially that this aspect is, of course, not very often acknowledged in public discourses. The fact that we have a long tradition of immigration, and it's not just people who've arrived since 2015 who are migrants in our country. This is just a similar figure, basically showing the proportion of first and second the proportion of households with a first and second generation immigrant in the European Union, and the change between 2008 and 2014. As you can see, essentially this is just to say that first generation immigrants born within the EU represent the larger proportion of immigrants in Europe, and that there has been an increase over time, and there has this increase is probably continuing, but again, migration is not a new phenomenon. Okay, so what do we know about the mental health of, and I'm going to try to distinguish asylum seekers and refugees from other categories of migrants. Most research has focused, as I've already said, on asylum seekers and refugees, and essentially what the data show is that in adults who are either asylum seekers or refugees, there are elevated levels of psychotic disorders, 2% versus 1% in the general population, levels of depression and PTSD that are also somewhat elevated, but that children whose parents are asylum seekers or migrants and refugees seem to be particularly impacted by mental health difficulties. As you could expect, the situation is probably worse among unaccompanied minors who face many more challenges than children traveling with their families. And the other very important issue which has already been brought up are the difficulties in access to mental health care among this particular population for many different reasons, including lack of knowledge about the healthcare system, the language barriers, perhaps cultural beliefs and expectations, both on the persons and the health professionals, and also lack of trust in the medical system if people have experienced different forms of violence previously. A really important issue which was shown by recent research is that really it's not only the things that happen to people before they left and during the course of migration that impact their health, but also what awaits them in the country of arrival. And in particular, I just wanted to cite a study conducted by the group of Mary Nordum at the University of Copenhagen, who have, in the Nordic countries, they have registers of people so they can study entire populations. And they did this study where all persons who've asked for asylum or obtained refugee status in Denmark are followed up over time across those medical registers and other forms of registers which they have. And what they've shown for the first time, most probably, is that the period that people wait for an asylum decision is directly associated with the level of all sorts of mental health problems, including severe forms of psychiatric disorders such as psychosis. And this, of course, is controlling for all types of other covariates, socioeconomic position, where people come from, etc. So this is just to say that people's living experiences in the country of arrival are really important with regard to their mental health. I also wanted to talk a little bit about data from migrants who are not refugees. Unfortunately, many studies which focus on migrants in general mix refugees and non-refugees, so it's a little bit difficult. This is why I just decided to talk about migrants who are not necessarily refugees. And we know that refugees are only a small part of migrants in overall. And the most consistent finding in mental health is that In general, migrants tend to have, or at least in countries where this problem has been studied, where this issue has been studied, migrants have higher levels of psychosis than non-migrants, including schizophrenia. I'm saying in the countries where this has been studied because most of the data come from the Nordic countries, the Netherlands and the UK. So really in Southern Europe or France, which is sort of in between, we don't have very good data about this. But there seem to be similar trends. And what the research has also shown is that this excess risk of psychosis is found in migrants, but also in ethnic minority groups. And there is actually currently discussion about the fact that ethnicity, and particularly being black, is maybe more important than the actual experience of migration, which goes back to experiences of racism and discrimination, which have been mentioned. There is a lot of discussion about the extent to which the risk of psychosis among migrants and people who belong to ethnic minorities varies across the contexts in which they live. And you may have heard about the quite consistent finding, which is a bit surprising, that actually people who live in neighborhoods where ethnic minorities are majority have a lower risk of psychosis than those who live in more mixed or mainly non-migrant neighborhoods. So that is somewhat paradoxical because migrant neighborhoods generally tend to be poorer, but there is a whole discussion about the social networks and social opportunities that are available to people in neighborhoods which are characterized by people which have many more people like themselves rather than where they're isolated. And again, that also goes back to integration and social inclusion. So other data about migrants' levels of mental health in general are that as much as migrants tend to have low levels of substance use at arrival, their levels of alcohol and other forms of drug abuse tend to increase over time. That could also be related, and especially in Europe, that could also be related to acculturation, if you will. And then for other disorders, there are no consistent data. Bipolar disorder or suicide, for instance, there's no evidence that migrants actually have higher risk. And finally, that's consistent with what I told you about refugees and asylum seekers. Migrants tend to have lower access to the medical health system when they do have mental health problems, and that also results in lower levels of psychotropic drug use. I just want to say a couple of words about descendants of immigrants, so second-generation immigrants, if you will. There is some evidence that levels of mood and anxiety disorders in this group are elevated, but there's much less data. And finally, another topic which is often not considered are left-behind persons, that is people, and this is an issue for international as well as for internal migrants. What happens if a person leaves their children or their spouse or their parents behind? What happens to them? There is some data from China and from South America in particular showing that levels of mental health problems and particularly mood disorders among family members who are left behind also tend to be elevated. Let me now turn to some data from France, which I wanted to show you to illustrate some of these findings. So I told you that I'm particularly interested in migrants in the general population, but I'm actually going to start with some findings from a very specific study conducted by a colleague of mine among migrant families who live in great poverty in the Paris region. So this study is called En Femmes, and it was conducted in 2014 among families, that is mainly women and children, who are actually sheltered. So they don't have permanent housing, and they have to get housing via the particular NGO which is in charge of doing that. You have to know that this was in 2014. We don't know the numbers for now, but at that time there were already 10,000 families that were sheltered every day by this organization. That's over 30,000 persons, and the situation has probably not improved since 2014. Most of these families are immigrants. Most are undocumented, but there are also asylum seekers and refugees in that group. And sort of half are single parents. What's complicated is that it's easier for women and children to get housing or shelter than for men, but probably about half of them are single parents. 20% have more than 3 children, and just another descriptive, 25% of women in this, experience domestic violence. So and the pictures just represent the conditions in which they're sheltered, because there are not enough shelters or specific centers. I don't know if this is also practiced in other countries, but in France these families are put up in hotels, which means that they live in conditions which are, clean, probably, but they're not really for families. And that poses a number of difficulties to prepare food, for children to have good sleep habits, etc. And the other problem is, of course, that these are actual commercial hotels, so they need to, if during high season, for instance, people are moved around, and that's also something that the study aimed to investigate, is the extent to which moving accommodation all the time was associated with the family's health. So we actually screened, the study included the CD, which is a standardized questionnaire on mental health problems and psychiatric disorders. And what the study found was that approximately 30% of women, so it was a sample of approximately 800 altogether, so about a third of women had clinical depression at the time they were surveyed. Almost 20% were at risk of suicide at the time they were surveyed. 63% experienced a traumatic life event at some point in time, and about a quarter had post-traumatic stress disorder during their lifetime, and 17% at the time of the study. What I didn't say is that most of these families, most of these women actually lived in France for 5 or 6 years on average. So they're not people who've recently arrived to France, they're actually people who have been in France for some time and have legal difficulties, cannot get are undocumented, and because of that they cannot work and they cannot get access to housing. So we found that depression and post-traumatic stress disorder were highly comorbid, as you would expect, and for post-traumatic stress disorder, the risk factors that were most significant were the departure from the country of origin due to violence. That's something you would expect, of course. People have post-traumatic stress disorder because they've experienced violence at some point in time, but also the residential mobility, which I've already mentioned. And so the, of course, the interpretation is that yes, people have great difficulties which they experienced prior to migration, perhaps during the course of migration, but again, the living circumstances in which they are, and of course this is a very particular, very poor sample, but still add to their risk of psychiatric problems. The other issue we were interested in was the mental health of children in these families, and actually children between 4 and 13 were also surveyed, we used the strength and difficulties questionnaire to ask the parents to report on some of their symptoms. We found that actually children's symptoms of emotional and behavioral problems were elevated compared to the general population, and what is interesting, I think, is that, of course, some of the mother's health characteristics were associated with the children's well-being, but also, I don't know if you can see this here, the children's living experiences, and particularly the fact that children did or did not like their housing facilities, and also the fact that they reported being bullied at school. What I should say is that what we also found in this study is that most of these children were born in France because, as I've said, these are families that live in France for some time. They were all vaccinated. They all had really good coverage in terms of primary care. But actually, neither for the children nor for the mothers, the mental health problems were identified or treated by any health professionals. Let me now turn to some data from the general population. And I want to talk about a nationally representative cohort study which was launched in 2011 called the ELF cohort study. It's not a study of migrants, it's just a study of the general population, of children in the general population of France. But approximately 10% of children in this study have a mother who's an immigrant, and another 10% have a mother who's a second-generation immigrant. So it's a great opportunity to study mental health in this general population context. And the study recruited altogether about 18,000 families across France, And at the time of inclusion, the mothers were able to express themselves either in French or in English, Arabic, or Turkish, which also made it possible to include migrants. And so, first, just a very rough description of the migrants. So the women born not in France and who don't have French citizenship in the study. As you can see here, they were generally either younger or older when they had children than the non-immigrants. They were more likely to have more than one child. They were quite likely to have an immigrant partner. 56% said that the father of their child was also a migrant. 10% did not live with a partner at the time of pregnancy and the child's birth, as compared with less than 5% in the rest of the sample. The migrant women tend to have lower educational level. They were more likely to be unemployed during pregnancy, and their partner was also more likely to be unemployed. And finally, as you would expect probably, they also had 7 prenatal visits is the standard prenatal care in France, so they were also more likely to have less than adequate prenatal care. Again, just some descriptives. Of course, immigration patterns have changed a lot in France as in the rest of Europe over time. And what you see here essentially, I don't know if this is easy to read, is that second generation immigrants in our study mostly came from Europe and to some extent from North Africa, in particular Algeria, Morocco, and Tunisia. But of course, immigrant women were less likely to come from Europe, and 37% of them came from a North African country, and 25% of them from a country in sub-Saharan Africa. So of course, in studying the relationship between migrant status and the women's or their children's mental health, it was extremely important to take into account the region of origin. So that's what we did, and I'm sorry this is a busy slide, but essentially in a single statistical model we studied both the mother's immigrant status, whether she was not an immigrant, either herself an immigrant and had obtained French citizenship, or was an immigrant and was still not French. If she was a one immigrant parent or 2 immigrant parents, described second generation immigrants. And at the same time we also studied the woman's region of origin in relation to perinatal mental health. And what you see here is that essentially we found no differences between migrants and non-migrants in terms of psychological difficulties during pregnancy, but when looking at postpartum depression at 2 months after the child was born, what we found was that women who were migrants and had not acquired French citizenship were 60% more likely to have depression. And this was particularly true for women who came from North Africa or sub-Saharan Africa, rather than other parts of the world. In the ELF study, we also have data on the father's depression, which is quite rare actually, and we found that 1% of families were characterized by both parents being depressed at the same time, as opposed to, well, of course, depression in postpartum is more frequent among women, but still it does happen also in fathers. And again, what we found here was that the joint occurrence of the father's and the mother's depression was more likely in immigrant families, and of course this is concerning, as if the mother is unwell, the father, if he's present in the household, can be a source of support for the mother. So we can think that even though these families represent only a small proportion of the sample, 1% as I've said, the fact that both parents are depressed is really problematic and can have a high impact on the children. And we also are now starting to have data about the children themselves, and in particular, one of the hypotheses that we were really interested in studying was the relationship between the mother's migrant status and children's developmental outcomes, because you may be aware of the recent research showing that there may be a higher risk of neurodevelopmental difficulties, and particularly autism in children of immigrants. And so data from the health cohort allowed us to study this, and we did that using two different scales that measure the risk of autism symptoms and language acquisition when the children are 2 years old. And these are self-reported scales by the parents, so of course that brings up some issues and some questions, but nevertheless they're relatively validated. And essentially what we found was that this is, if you just look at the left side columns, we did find a small increase in the scores of autism symptoms among children of first generation migrant women in the study. And sort of paradoxically, we also found that they generally reported that their children had better language acquisition, but I'll show you a little bit more on that in a second. What we found was that this risk, or these excess levels of autism symptoms were most pronounced among children of women who are first generation immigrants from North Africa. And I'll just skip this. And that actually the risk of symptoms of autism was highest among, just look at the right hand side of the graph, was highest among, children of immigrants had a likelihood of both having low language acquisition levels and high levels of risk of autism, which implies that there may actually be really something having to do with the risk of neurodevelopmental disorders. And of course, because this is a cohort study and the children will be followed up, the next stage will be to actually use later data to confirm whether we do find this elevated risk of neurodevelopmental problems in the children, and also to examine their healthcare access. Just a few words about the possible mechanisms that could explain elevated risks of different types of mental health problems among migrants. And many of these have already been mentioned, so I'm not going to talk about this at length. As I've already said, there are pre-migration factors, such as the reasons that may drive people to leave their country, and this is especially true for asylum seekers and refugees. There are also violence, and also just the sheer separation and loss of social networks that happen during migration, which can also be detrimental to people. And then, and maybe I insist on this a little bit because this is actually probably something that we can have a say in or try to improve. There are all the post-migration factors, including administrative uncertainty, sometimes detention as is practiced in many countries. Of course, issues of social exclusion or cultural dissonance, which have already been brought up also earlier, and what has been referred to as acculturative stress if people have a difficult time integrating. So what are the resilience factors? Well, of course, it's sort of the upside. First of all, anything that can help social integration will likely be beneficial. So that means social activities in schooling and children, for instance, as well as activities that help children develop social capitals, so just relations with others. I mean, people move to another country and they can be sometimes completely isolated and don't have support don't have networks and have no support. So anything that can help people actually improve that support and the sense of belonging is beneficial. And of course, in adults, as has already been mentioned, education and employment, which are key to then have positive and favorable living conditions. And then just to mention access to treatment, because all the studies show that migrants tend to have low access to treatment. There is much to be done in improving the training of health professionals, but also social workers who are sometimes more frequently in contact with this population, to either help them screen for mental health difficulties in this population, or help them have the tools and the networks also to be able to help people in case of actual psychiatric problems. Translation services, that has already been mentioned, but it's essential and yet not implemented in many places. And also, people may not have the same knowledge of mental health services and mental health in general as Europeans, to say it broadly. So any types of outreach services that can help actually screen for mental health problems where people are can be beneficial. And I just want to mention a project which I'm associated with, which is the Strength program. It's a research study funded by the Age 2020 program. And it's a program that's actually designed to help refugees and asylum seekers from Syria access psychosocial help, if you will, via the idea is to actually make available the Program Management Plus program, which the WHO validated for psychosocial interventions in low-resource settings in countries where there are no psychologists, no psychiatrists. And it's a very short intervention that can be implemented by helpers, so people who are not psychologists, not psychiatrists, who can be trained and then need, of course, to be supervised, and who can help people address, of course, it's not for people who have post-traumatic stress disorder, it's for people who have mild distress. But, of course, this is just recognizing that during the course of migration or after migration, people are faced with many types of problems and difficulties of daily living that they are sometimes in great difficulty, they can have difficulty solving. So it's just to give them a little bit of help and try to perhaps prevent the occurrence of more severe anxiety, mood disorders that can occur if people feel really lonely and facing great challenges after migration. And of course, and that already has been mentioned by the previous speaker, efforts to coordinate healthcare services with other types of services, social and legal services in particular, because clearly if people are in distress because of their overall situation, it's really difficult to help them without addressing those determinants. This is the last slide about directions for future research. There isn't enough research about the mental health of children and descendants of immigrants during the course of time. One issue that really comes up is we use the validated mental health screening tools, which are used universally, but there could be more work probably to actually validate them, or at least do qualitative research to try to understand what people understand by some of the constructs. In some of the constructs that are measured in scales of depression. I mentioned scales that screen for autism symptoms. Clearly, the ELF study showed us that some answers were more frequent than they should have been probably in certain groups. So clearly there is need for more efforts on that end. The context of migration, both the circumstances in which people migrated, where they come from, but also comparative research across Europe, for instance, to try to understand the extent to which migrants that come from similar settings and similar situations in different countries do differently, or maybe they do the same, and that will also give us an idea about what is it about migration that can actually have an impact on mental health. And finally, there's need for more research to really evaluate effective ways of preventing mental health problems in this group, but also increasing access to adequate healthcare, and that can address people's needs. And especially, this is just a picture of multicultural Europe, to try to go back to the general population idea which I started with. Thank you for your attention.